Greetings, aspiring orthopedic clinical specialists. We are going to talk through the pelvis and the SI joint scenario. So what we'll do is I will take you through this scenario. This one's a little bit long, but I'll take you through it and I'll tell you key points that I gleaned from it as I read it. And as I'm reading scenarios, we want to pay attention to a couple things. We want to attend to every piece of information we're given, because if we ignore a piece of information, potentially we get a question wrong. And we want to think about kind of three areas: examination, differential diagnosis, prognosis, and intervention. Those are kind of how questions are written. So we want to think about the information that's going to help us answer those types of questions. So when we look at this scenario, 21-year-old female, anytime I'm given an age, I pay attention to it because there are certain conditions that are more likely with certain ages. So when I see 21, there's certain conditions that are popping into my head and other conditions that aren't, versus if this person was 81. So 21-year-old female, same thing with gender. Gender can mean certain things. There are certain conditions that are more prevalent with certain genders, so I pay attention to that. We're a collegiate runner, so running is going to mean something to me. I'm thinking of the demands of that sport. I'm thinking repetition, all those type of things that start to come into my head. And she's coming in with right low back and hip pain. So again, I'm starting to think of some things: stress fractures, SI joint, those kind of diagnoses are coming into my head. We have a 2-month history of intermittent right-sided low back pain. So we have a time frame here. And we have some description of it, of the back pain, and as well as the hip pain. We have intense right hip and groin pain. So now we have pain in the hip and the groin, and she has pain, deep pain in the hip that rarely goes away completely. So we have some kind of symptomatology here. She's talking about the pain is getting worse over the past few weeks. So that's really important as well. We've had this pain for a couple months. Now it's getting worse, and it correlates with her increased mileage. So that should give us a little alarm bells going off in our head. Her symptoms are not relieved when she lays down. So that also makes some sense to us. We're given some more history that she's afebrile. She has a history of irritable bowel disease. Anytime I'm given a comorbidity or a history of anything like that, I pay attention to it because it could change my prognosis. It could change an intervention. It could change a diagnosis. So I always pay attention to that. We're given a medication history. We've taken corticosteroids for that over the past 2 to 3 years. We talk about her weight and how it oscillates. And she's talking about having trouble holding down food while she's had some flare-ups from her inflammatory bowel disease. So that also starts to come into my mind as part of this hypothesis, part of this differential diagnosis. And we talk about standing. So now she's had x-rays. So we have results of the x-rays that were done 3 weeks ago, and they were negative for pathology. So that makes that is a lot of information for us right there as well, a lot of good information, because we've had imaging. If we were thinking about a stress fracture or something along those lines, we've had imaging, again, just an x-ray, but it's been negative. So we know that at this point. Now we have findings from her examination. So we talk about the hip pain that we had. We have a positive Fortin finger test. So we have to know our special test and what they mean, and sensitivity and specificity. We have some gait information here, and that it talks about frontal plane instability, and it's worse during running. We have manual muscle tests. So we have strength information, and we have a little more information presented in terms of pain and what elicits it, what types of muscle contractions: hip abductors, rectus abdominis, and hip adductors. And then we have some palpation information as well. And we have some techniques. We have gapping, provokes groin pain, and it gives us that thigh pain on the right side. And we have a fader test, which is positive for the groin pain and gives us some of the thigh symptoms. We performed central pressure on A to P, or P to A pressure on the lumbar spine. And it recreated some discomfort, but it didn't produce that comparable sign. And she has difficulty recruiting transverse abdominis as well as pelvic floor. And we have some more findings. We have our neurological Our neurological screen is normal. So that's a big deal for us as well. If we were thinking some kind of nerve involvement, they're telling us that was negative. We have a negative sign of the buttock. We have straight leg raise, Ganselin's, compression test. So again, we have to know our special tests and what they are testing for and what a positive and negative test mean. And then we're told with lumbar motion, we don't have any peripheralization or centralization. So we're given information about that as well. But that does, lumbar flexion extension does give us some mild increases in lumbar pain, but we don't have peripheralization and centralization. And lastly, we're told femoral sciatic nerve testing is unremarkable. So we're given some neurodynamic information. So we're given a lot of information here, but I kind of went through it step by step, and each step of the way, kind of what I'd be thinking of during each of those pieces of information that I'm gleaning. And then we're asked, most likely pathoanatomic hypothesis. And we're given cancer, and we're given low back pain with radiation, hip OA, and then we're given stress fracture of the pelvic girdle. Even though we have a negative x-ray, stress fracture is the best choice here. None of those other options would make any sense. Cancer, we don't have any other symptoms that would make us think cancer. Hip OA, she's too young for hip OA. And low back pain with radiation, our neurodynamic testing was negative, and she's not reporting any radiation into the lower extremities. So the best choice here is a stress fracture. Some of those other options may look appetizing to you, but there's information in this scenario that gets you away from it, or there's information that's not in the scenario as to why you wouldn't choose it. So we have to go through that process. Our next test, what radiological test would be most diagnostic at this time? And we're given a CAT scan, an MRI, plain films, or scintigraphy, our bone scan. Our choice here is going to be MRI. It's the most sensitive and specific, and it gives us the most information to rule in and rule out any pathology that we're thinking. If it's soft tissue pathology, the hip, it'll help. A stress fracture, at this point, it's going to help. Where a bone scan is specific for a stress fracture, this can help us look at the labrum of the hip and some of the soft tissues. So an MRI is the best choice here because it's going to give us the most information. You are expected to know imaging on this exam, not that we have to be radiologists and know specific shots and scans that we want, but you are expected to know which one is better to rule in or rule out a certain condition, or which one might be more appropriate at a given time. So you do want to review that if that's not information that you are that is in your forethought. So for this one, it would be an MRI. And our next question, we refer the patient back to the physician, and now the physician refers them to a physiatrist, and they get different x-rays of the hip. And the physiatrist performed an SI joint injection, an anesthetic injection. And the patient noted a 50% reduction in all their pain 4 hours after the injection, but had the discomfort return the next morning. So again, that's really good information that we're given right there. Had this procedure done, it helped to alleviate the symptoms, but then the symptoms came back. And then it's asking us, which of the following diagnoses are most likely based on this new information? And we're given FAI, so femoral acetabular impingement, an adductor strain, a lumbar facet pain, zygopophyseal pain, or sacroiliitis. Based on what we're given, sacroiliitis is the best information, is the best choice here, because she was given an injection into the SI joint, and the scenario states under fluoroscopy. So we know it went into the SI joint, and it relieved all her symptoms. Okay, they came back, but it still relieved all her symptoms. So we're confident in saying that that is the pain generator. Those other ones don't make any sense based on information that we were given in this scenario. If it was FAI, an injection to the SI joint would not have alleviated her symptoms. And if it was lumbar facet pain, an injection to the SI joint would not have alleviated her symptoms either. So sacroiliitis is the best choice for this patient based on that information. And last question we're asked, which treatment is most appropriate at this time? And we're given grade 4 or 5 hip mobilization. We're given lumbar motion and posture training. We're given femoral nerve flossing, and we're given transverse abdominis and pelvic floor training. So based on everything that we've gleaned so far and additional information we're given, we don't think this is a hip issue. So mobilizing the hip joint is not appropriate. We don't think it's a lumbar spine issue. So doing things to attempt to centralize symptoms, we were told that didn't work. So that's not an appropriate choice. Femoral nerve flossing, we're told that we didn't have, that the testing for femoral nerve was negative. So that's not appropriate. But we were told that she had issues with abdominals and pelvic floor. So transverse abdominis and pelvic floor training is the most appropriate choice out of those options that we are given based on the initial symptomatology and based on the additional information that we were given. So that was a lot to unpack, long scenario, but hopefully you saw by going through that, we utilized each piece of information that we were given to answer these questions appropriately and to rule out certain choices in these questions. And then we were given additional information. We just layered it on top and then use that information to make the best choice. And that's how we want to attack these scenarios. We want to be able to use all the information that we're given. Again, if we had ignored some of that information, if we missed the piece about the femoral nerve and sciatic nerve testing was negative, we might have chose nerve flossing here. So this shows us, again, that we want to be attentive to all the information that we're given in a scenario and really put some good thought into it. So hopefully this helped you get through this kind of pelvis SI region.